Welcome and thank you for tuning in to A Sound Constitution on CHLY 101.7 FM with Ryan, Matt, Aminder, Alicia, Matthew, and Emily. We are fourth year BSN students at Vancouver Island University in Nanaimo, BC. We are working to demystify health issues affecting our community, bringing you evidence-based information about healthcare. This information is for educational purposes only and does not replace the advice of your primary healthcare provider. We would like to start our show by acknowledging that we are on the unceded territory of the Snuneymuxw people with a broadcasting range that overlaps the Courtson and Sliamon territories. This acknowledgement is done with the gratitude to the Snuneymuxw people and with the intention to increase awareness about truth and reconciliation processes and efforts on Vancouver Island. Additional information and resources surrounding Snuneymuxw history, reconciliation, protocol, and land acknowledgement can be found on our Facebook and YouTube pages.
Hello, thank you for tuning in to A Sound Constitution. My name is Emily, and helping me kick off our new season here is Ryan.
Hello, hello.
We are super excited to be back with you this semester with new shows, new look, and a new logo on our Facebook and Instagram pages. This season, we're going to be talking about how global health emergencies affect different populations and some of the ways that we can cope with that. Today, we're going to provide some background to global health emergencies and pandemics, such as who is involved and kind of what that means to you. So first, let's talk about what a pandemic is. According to the World Health Organization, a pandemic is defined as an epidemic occurring worldwide or over a very wide area, crossing international boundaries and usually affecting a large number of people.
The World Health Organization also defines an epidemic as, quote, the occurrence in a community or region of cases of an illness, specifically health-related behavior or other health-related events clearly in excess of normal expectancy.
Current and past examples of some epidemics are COVID-19, currently ongoing, HIV, SARS, the 1918 influenza pandemic, also known colloquially as the Spanish flu, and the 2009 H1N1 influenza pandemic, colloquially known as swine flu.
One of the primary things that we do as healthcare providers during the incidence of an epidemic or pandemic is something called contact tracing. Now, what contact tracing is the process of identifying, assessing, and managing people who have been exposed to a disease to prevent onward transmission.
When systematically applied, contact tracing will break the chains of transmission and is an essential public health tool for controlling a virus.
So, moving forward, we just want to discuss some of the important names in like epidemic and pandemic management with you, going from an international scale all the way down to a provincial scale. So Emily's going to start off with some of the international contenders right now.
Yeah, so one of the big players that everybody hears about quite often because they kind of exist globally is the World Health Organization. And the World Health Organization is associated with the United Nations, and it's formed up from healthcare workers and researchers and epidemiologists that are from the UN member states. And their role in a pandemic is to support the member states in epidemic preparedness and support international pandemic response training, as well as coordinate member state response to pandemics and seasonal influenza outbreaks. And finally, they develop standardized processes to major epidemic prone diseases and strengthen biosafety and security, as well as outbreak preparedness. And then within Canada, we have the Public Health Agency of Canada that kind of covers the whole country and is made up of some of our top doctors and epidemiologists. In regards to a pandemic, their roles are to manage emergency stockpiles of medical equipment and antivirals, as well as detection of disease and control of disease planning, public health and safety, such as travel alerts, immunization and vaccine recommendations, emergency preparedness, health promotion, injury prevention. As well as they also provide research and statistics and health education to the public and to healthcare providers such as ourselves. Now Ryan is going to talk about some of the local players that we have within our province.
Yeah, here in British Columbia, we have some really amazing provincial health resources that are working on our side. One of the most obvious big ones is the BC Centre for Disease Control, or BCCDC. The BCCDC provides both direct diagnostic and treatment services for people with diseases of public health importance, and analytical and policy support to all levels of government and health authorities. BCCDC also provides health promotion and prevention services to reduce the burden of chronic disease, preventable injury, and environmental health risks. So right now, the BCCDC, most of their resources are currently being dedicated to management of COVID-19, research of COVID-19, and specifically the effects of COVID-19 and its management within British Columbia and the specific populations and demographics that are here in our province. So the other really relevant player, at least for those of you who live on Vancouver Island, is Island Health. So Island Health is the local health authority for Vancouver Island, as well as areas of the mainland north of the Sunshine Coast and south of the River's Inlet. Island Health serves more than 850,000 people and is responsible for identifying public health needs, planning services to address those health needs, and ensuring the funding and management of those services. Island Health delivers their services through hospitals, clinics, centers, and long-term care facilities. Essentially, if you are within the Island Health region and you attend any non-private health center, you are probably attending some kind of Island Health managed facility. For instance, Nanaimo Regional General Hospital.
Thanks, Ryan. Later in the episode, we have an exciting opportunity to talk to Dr. Alana Devereaux. She's faculty at the Vancouver Island University for the nursing program, and she did her PhD research in how pandemics tend to affect nurses, specifically in her case during the H1N1 pandemic in 2009. But before we get into that, I think that there was a clip that Ryan had for everyone.
We're going to play you a clip from someone who, if you pay attention to the news here in British Columbia, is probably a pretty familiar face and familiar voice. We're playing you a clip of our provincial health officer, Dr. Bonnie Henry. This was from September 17th of 2020. Just some advice from her on the current state of physical distancing in British Columbia and sort of the expectations of the general population, and just some general words of wisdom. So, without further ado, here's the clip.
So we know now that living with COVID-19 requires all of us to consider that we need some give and take. We need to compromise. I can appreciate as much as anyone how difficult this can be. But it is essential for the well-being of all of our communities, and it recognizes the fact that we are going to be living with this virus in our communities for some time. It is not either or. We must continue for our community well-being, both the economy and our health. The BC Restart Plan is the focus of public health and many, many people supporting these efforts. And it is to have as much as possible opening and functioning safely in our communities. And we know that we've had essential services going through this entire period of time, whether it's in healthcare, our food system, our grocery stores, our pharmacies. There are many different essential services, and we've adapted. We know that how important it is to have workplaces, grocery stores, restaurants, and schools open for the well-being of our community. And on the other side of the equation, we need restrictions and at times closures are in place to limit the exposures to known higher risk activities and locations. And we have had to modify those over the last few weeks as we've seen cases increase. This give and take is not easy, but it is what will keep us safe and functioning in the months and weeks ahead. And I have said it many times, it is not forever, but it is what we need to do together now. And this is going to be our most challenging year. But as we work together, we build that resilience together, and that's what will keep us safe and help us through this and help us bounce back. One of the things that is really important at this point of time is the restrictions that we have on gatherings. And we have maintained a constant, consistent approach of no more than 50 people. This is another protective layer to contain the spread. It means reduced numbers of people, that when somebody inadvertently brings the virus into your collection of people, that group, it can't spread too widely. But we are seeing it spread, even in smaller groups, and we all need to take a step back and reassess. It's very important to remember that 50 people is an upper limit, and only where you have the space to do that to maintain safe distances. It needs to be scaled down based on the space that you are in. And I need everybody to understand that now. Whether it's inside or outside, maintaining safe distances is important. Keeping your numbers small is important. Just because you can fit 50 people into your small back garden does not make it safe. And that's where we're seeing transmission, and we're seeing transmission to people we care about, and now we're seeing spillover into people like grandparents, like elders, who are more susceptible to having severe illness from COVID-19. We are in a global pandemic, and these are the sacrifices we need to make. As we have seen, many businesses are only able to safely accommodate a few people, and the same applies for our homes, inside and outside. Regardless of our location, when we're socializing with others, smaller is always safer. The compromises we have made to keep ourselves, our loved ones, our communities safe means seeing fewer friends and family members, for now. The compromises, our small groups also need to be the same small groups. Spending time with different friends on different days significantly increases our personal risk. It means that we are now exposed to many more potential chains of transmission, and it's a continued source of transmission that we are seeing in our communities now. So when planning our activities, whether it's a play date for your kids, a weekend dinner party, a group of friends getting together, ask yourself if the people are part of your safe six, your group of people. Our grandparents, our aunties, our workplaces, our communities depend on this. Social connection, we all know, is essential. We are social creatures. We need that connection in our life for our mental and our emotional well-being. But now is the time to stick with six, to keep our groups small and only spend time with the people we know, with our safe six. The restrictions and precautions that we have put in place here are not forever, but they are needed right now. By stepping back now, we can protect those who are most vulnerable and keep the people we care about safe. And we can keep going with the workplaces. We can keep going with our surgical restart, we can keep going with the all-important education that our children need in school. So this month, let's remember, we need to get ready for respiratory season. We need to hold steady with our layers of protection and step back from our socializing with different groups. And that way we can step forward with the routines that will keep our communities and our loved ones safe. And of course, we must remember more than ever, as we get frustrated, as we get tired, as we get into respiratory season, we need to remember to be kind, remember to be calm. We will get through this storm, and remember to be safe.
You are listening to A Sound Constitution on CHLY 1017 FM. Today, Ryan and Emily discuss the processes that go on behind a global health emergency or pandemic.
Up next, we have an interview with Dr. Alana Devereaux. She is a registered nurse and an instructor in the Faculty of Nursing at Vancouver Island University. Her specialty is on pandemics and pandemic response, so we decided to ask her a few questions and gain some insights from her on this subject and the state of the world we're in right now.
So my name's Alana Devereaux, obviously, and I'm a PhD prepared registered nurse, which means that I graduated from nursing school and I went on and got my master's and my PhD during the H1N1 pandemic.
Right.
So my PhD was actually in nurses' experiences working frontline, delivering mass vaccinations during the H1N1 pandemic. And in order to do that research, in the course of about 7 years, I developed a concept analysis as to what it means for what a pandemic is in the nursing profession, what it means when it happens, what it means to our workload, how it impacts nurses, how it impacts overall quality care for patients. And then with that kind of development of that concept, looked at how nurses worked during H1N1 and compared it to past infectious outbreaks. So epidemics such as SARS and the 4 previous pandemic influenzas of the 20th century. So that's kind of my background while nursing and being a teacher.
That's a lot. That's awesome though.
I don't know if it's awesome, but
I mean, it's a lot of work. I would love to be able to get to that point at some point. But so
From the perspective, oh, sorry, you go.
oh yeah, I was gonna say just from you said that you kind of had to find out what a pandemic was for nursing. What did you kind of like come to, like, to summarize that, I guess?
well, in the field, it was more so what it meant when a pandemic happens in the nursing profession. So, for example, what makes a pandemic occur, and then how do nurses subsequently deal with it when they're faced with it, whether they be in acute care or whether they be in public health. So that was kind of what I looked at. So basically, when an infectious outbreak happens, nurses are impacted frontline differently based on the context they work in. So for example, in public health, those are going to be the bulk of the individuals, vaccinating people, implementing quarantine measures, contact tracing, etc. Whereas the people that work in tertiary care, how they deliver frontline, medical care to acutely sick patients, how that differs based on, how they present. And that's basically what I looked at. So pandemic means so much more than just infectious outbreak. It really depends on what profession you're looking at. So like medical physicians have to worry about the diagnostics of it type thing, and nurses have to deal with the actual hands-on care of dealing with someone who's acutely ill and in a situation where that illness can be spread. And it causes a lot of discomfort, and it can cause a lot of anxiety and just a lot of impact on our way of being as nurses. I don't know if that makes sense or not, but
Yeah, no, that I think that definitely makes a lot of sense, and I think that even us as students are kind of seeing that being in the hospitals right now and everything like that. It really kind of changes yeah, our way of being and how we interact with people and how patients get to interact with their families and everything like that. It just kind of shifts the whole thing on its head.
Significantly, a massive amount. And yeah, we can get into it further as we
Oh
move
yeah.
through the session, but definitely it definitely has changed the landscape of how nursing is delivered and how students even enter into nursing like yourselves.
Yeah.
And it won't change anytime soon.
No, yeah, we're kind of stuck in here, living it for a while.
Yeah.
Yeah, and even working in mental health, over the summer, like it's changed everything, even the areas that are sort of on paper at least sort of the least affected by something like this. Like it's kind of incredible how the entire healthcare landscape has changed. So another question for you here. So working with the mass vaccination campaigns during a previous pandemic, from your experience, can you talk a bit about what that was like and what some of the challenges were, what might have been successful?
Sure. So I think that's a great question. And we need to remember, again, it always comes back to like what they learn in nursing school, what you guys learn in nursing school about how it's so, situation specific. And so my area of focus really was looking at an urban large center in Canada at the time I lived in Ottawa, and looking at those nurses' experiences, coming together and delivering mass vaccinations in that urban context of a city of about 1 million people. And not only that, they had the blessing, or whatever you want to call it, the curse, the mere fact that they were also the capital of the country.
Mm.
So those individuals in those situations had to react really quickly. But the difference being with the H1N1 pandemic is that, as you guys are well aware, that was a flu virus. And so the reasons why vaccinations were so much easier to obtain during that situation was because we have a seasonal flu every year. We've encountered past influenza pandemics. We've never before had a coronavirus pandemic. Some of the challenges for these individuals were really the fact that, and as we move along in nursing school and as we turn into registered nurses ourselves, we recognize that a nurse is not a nurse is not a nurse, right? So we can see the variety of different practice areas where you can go when you graduate, and you specialize when you go in those practice areas, right? Like you learn more of the information and the knowledge you need to be an effective nurse in those practice areas, if you follow me. Mm-hmm. And what happened with H1N1 is that this kind of happened overnight, the development of this pandemic, this flu pandemic. And so public health nurses very quickly, the research shows, in the context that I studied, but of course in other areas across Canada as well, when I looked at the research and the literature, were kind of thrown into these mass vaccination clinics almost overnight. So even though municipal, provincial, and Canadian governments were well aware, were well established within the framework of an ongoing pandemic, and we're just literally waiting for a vaccine to be, secured and produced, very much like what we're experiencing right now. It was almost like the data shows that nurses working in these public health agencies across the country were not given a lot of notice as to when to expect the clinics to be open. So it wasn't a matter of, clinics, are they going to happen or are they not? Clinics always were going to happen. It was just dependent on when the vaccine was, again, secured and then produced in the mass quantities that were required. So the biggest challenge was, from the perspective of the nurses, of course, I need to really highlight that's what I studied, is that they were not given the training, the preparation, the materials, the time, and the support to go into these clinics. I'm circling back to my first point of how a nurse is not a nurse is not a nurse. If you take somebody who's worked in public health for 20 years in like healthy babies, healthy children, departments, and you throw them into a surgical ward, they're not going to function well, right?
Absolutely.
They're not going to be able to, and not that they can't do it, because of course we teach all nurses in nursing school and continued professional development, how to learn and how to review and where to go for the information you need, right? But I mean, I've been a nurse 12 years, going over 12 years. And if you were to throw me on a surgical unit right now, I would struggle.
Yeah.
And
there's a learning curve for every area.
Exactly. So you take these nurses that were in public health agencies, literally coast to coast across the country, and kind of like knowing that something was coming, because of course they were living through the pandemic themselves, right? And then overnight, sometimes 24 to 36 hours, being told, by the way, we've had the vaccine, it's ready to go. Clinics are starting tomorrow morning at 9 o'clock. And you're going to be working from like 9 to 5 or 11 to 11 in this area of town. And you're an immunizer and you're a supervisor of a clinic. And so that lack of time given to individuals to actually mentally prepare to go into these roles was actually shocking, because they were like, well, I haven't given a needle in 14 years.
Yeah.
Some of them. I haven't actually dealt with one-on-one, acute psychomotor skills of a crying baby, because I worked with older adults and healthy aging for the last 7 years. So it was a sudden and very dramatic shift in the change of their roles and the psychomotor skills that they were expected to perform. And so it caused a lot of anxiety for these nurses, and a lot of discomfort in their roles. And so that would definitely, and when I looked at this, obviously, sample of my PhD study, of this handful of nurses in Ontario, but when I looked at the data that was being collected and across the country, the similar results were popping up. So the biggest challenge and the biggest thing we were all left to ponder then as researchers, as academics, as strong nursing voices in our field, is why was this way? We knew it was just a matter of getting the vaccine, right? So even though there were certain elements they couldn't incorporate into training practices for these nurses, they could have prepared them a little more. They could have given them modules. They could have given them refreshers on what it is to administer an IM, for example.
Mm-hmm.
Yeah.
What are the protocols that we look at after, when you're waiting for somebody in the waiting area and you want to make sure they don't have an adverse reaction, right? Refreshers on that stuff that wouldn't have mattered what was actually in the actual material vaccine itself.
Yeah.
That was the biggest challenge. So again, cycling back to my first comment of how a nurse is not a nurse. So as not a nurse, like we're not expected to know everything all the time.
Mm-hmm.
Yeah.
They needed time to get ready, both mentally and physically, to prepare with the psychomotor skills. And materials also around, and people were really nervous. This is a new vaccine, and you're going to see that now with the coronavirus vaccine, even newer than, because we're used to flu vaccines, right?
Yeah, this is a totally new thing that hasn't existed before.
Exactly.
And then you've got your patients who are coming in and they're nervous. They don't know when they can get a vaccine or if they should get one, or what, it's new to them. So that's anxiety inducing in itself. And then you have the nurses who are also feeling anxious. And I feel like that can kind of, I obviously wasn't a nurse in that position, but I can imagine that ends up kind of just amplifying everybody's anxiety, because we're all kind of already on edge, and then it just kind of builds up from there.
Exactly. So how we reduce anxiety in any, especially in practice, professions, is by practicing, right? It's going in and reviewing the techniques and the skills and the knowledge. But the biggest caveat about that is that you need the time to do that. Like nurses that I talked to and others that were interviewed in the literature felt the same. If they had been given the time, like they knew weren't going to know the exact day, but if they had been given a time frame and maybe even links to those resources and time within their own jobs to go and have the time to review. Also, too, what was really challenging for these nurses is that, I think it was almost over 80% of the population I worked with were taken from their job and placed, they were deployed into frontline vaccination clinics. In Ottawa, there were 6 across the city and 2 roving clinics. And it wasn't like they didn't have a regular full-time job before these clinics. Does that make sense? So they were in these roles, taking care of caseloads of people in the community in a city of 1 million. And all of a sudden were taken from their roles with very little notice and placed into these mass vaccination clinics for, a few months, and were given very little time to kind of wrap up their ongoing role, what they were responsible for. So they felt very kind of anxious and almost like a moral distress over leaving their clients seemingly hanging in the city. Because just like acute care nurses in tertiary care settings, in your hospital settings, people don't just get sick with COVID now. if that makes sense. There's still those same conditions that are ongoing.
Yeah, it's not just going away because we're in a pandemic.
Yeah, cancer diagnoses aren't stopping. People are not having heart attacks because all the resources need to go toward COVID, right? And so that was one of the biggest challenges. It's like, give us some time. Let us prepare both for the new role and to wrap up what we are currently taking care of, so that clients aren't left hanging and our new clients can feel a lot of trust in the things that we're going to provide them with.
Yeah, that makes a lot of sense. Like you said, it's tough for everybody involved. On that, like, how do you feel like, even though it's from a nurse's perspective, how do you think that may have affected patients? Like, obviously there's some anxiety that they already had being in a pandemic and waiting for this vaccine, but what's kind of the fallout from those nurses' experience?
Again, I can only speak to the study that I
Yeah.
completed, Emily, but nurses felt more supported by the community than they did by their upper management in the agencies that they worked in.
Wow.
So, of course you get your occasional disgruntled client, right? That is super angry about the long wait, etc. And we can talk about that if you like. But and their nervousness and their own anxiety around contracting H1N1, because specific to the H1N1 pandemic, most flu viruses and seasonal influenzas every year attack the elderly and the immunocompromised. And with H1N1, it was so novel in that the people that were getting sick and subsequently dying were very young. Mm-hmm. They were teenagers. They were, 31-year-old healthy marathon running lawyers. Like, it wasn't, you weren't seeing that kind of death rate happen in the elder population like you do with seasonal flu and complications of it. And so people were just so grateful to get the vaccine when one was secured, especially with these younger people passing and getting sick, that most of the time people thanked the nurses. They were okay with the nurses going a little bit slower. And this is, again, coming from the nurse participants that I interviewed. Mm-hmm. They were very much appreciative of what the nurses had to go through in order to make this work. Because, again, these nurses were exposing themselves to hundreds of people in the run of a day. Yeah. And I can tell you in addition to my interviews that I did, 6 months of interviews, I attended every clinic that was being delivered in on Ottawa, and walked around those clinics for hours and as an observer and doing kind of like data collection, almost like a windshield survey, if you know what I mean.
Yeah.
And so just seeing how they were operating, taking care of these people. And for the most part, they were really receptive. And I just feel that nurses themselves had this guilt, like you were asking about, if they had negative patient outcomes. I think they had guilt because they felt that they were not being the best they could be had they been provided with adequate time, support, and training from their management.
I think I would feel the same way if I was in that position. Yeah, absolutely. I mean, I remember back then, because I was just graduating high school at the time that this was going on. And yeah, it was very strange to be like hearing about a flu that's affecting people that are around my age, and it was very anxiety inducing for everybody, for myself, including everybody I know. So yeah, it's good to hear that was, even with all of that, even with all the anxiety, there was that still kind of like respect between towards the nurses and everything. But it's unfortunate that the nurses didn't feel supported.
It is, and that was the biggest takeaway I actually got from my project, was how little they felt included in the planning, how dictated they were to, and how their big bodies of knowledge weren't used. And so the title of my dissertation, which is my PhD work, is actually called Nurses Implementing the Plan Without Planning the Process. And so it was
a great title, first of all.
It was very discouraging for some of these nurses. They felt so like we had this wonderful big body of knowledge that we spent years developing, because as much as I said earlier, how there were nurses that haven't given a needle in, 7 years, whatever, based on the area of public health that they were working in, there were also nurses that specialized in delivering flu clinics every year. And there were nurses that specialized in delivering school-age clinics every year. So although they didn't do it to the magnitude of a pandemic, implementing these big mass clinics, they were used to implementing clinics and delivering vaccinations. So why weren't they interviewed? Why weren't they brought into these planning meetings and be like, okay, we know we're going to blow it up because it's going to be on a mass scale, but why? But these are things that work for us when we need to vaccinate a lot of people in a short time. These are the processes that work. These are the ones that don't. And like really utilize that knowledge, because that's genuine expertise, you know, from years of work in the front line. And to have that just be so devalued and not accessed by the higher ups who are planning these clinics, like the healthcare professionals that were like health administrative professionals, medical officers of health who are physicians, generally 9 times out of 10. It was really demoralizing for these nurses. So not only are they thrown into, you know, literally into these clinics overnight, literally some of them, if not 2 days before, they weren't even asked for the things that they had kind of spent years refining.
Yeah.
It made a lot of people really question, am I respected? Is my knowledge valuable? Am I valuable? It had a much longer lasting impact in the agency years after.
Do you feel like the system has changed significantly in a positive way?
Let me make kind of a very broad statement. Okay.
Yeah.
I think historically nurses are not valued.
Yeah.
And I think we're not, you know, and that just comes from, we are valued in the sense that people understand and they respect us. And there for those months at 7:00 every night, especially here in the city of Nanaimo, people were ringing their bells and clapping and, you know, but when it comes to really recognizing the body of knowledge that nursing contributes and how separate and distinct it is from medicine. Yeah. I mean, we don't help them, we complement. We're complementary disciplines, right? So, you know, I don't know. I really don't know how to answer that question. I feel in my heart that we're still undervalued. I feel like that whole like just a nurse phrase is still there.
Yeah.
Even myself, you know, I am a PhD educated professor who spent 13 years in school, and I still get the question asked to me, why didn't I go to medical school?
Yeah.
Do you know what I mean?
Yeah.
So it's very much like the lesser of the two. And even at different meetings I sit at now, sometimes I sit back and go, no one's listening.
Yeah.
Because I'm a nurse or this person's a nurse. And, you know, it's quite upsetting sometimes. It's very upsetting.
I feel like in a limited sense I've experienced that as well, and I've seen that. And I mean, even people just personally, why is a nurse different than a doctor? Like, what do you do differently other than just like carry out their orders? And it's like, no, we're actually like very independent in our practice and thinking and problem solving and all of this. And people are like, when I go into that, people are very surprised. So yeah, I think that you're right. There's not a lot of sort of general understanding in the population of what makes a nurse.
And that's why I appreciate what you're saying, that you said, Emily, because we need to be the ones to tell people. And I think that's how we're going to actually instigate change, is by like, well, actually, those orders that you're talking about probably wouldn't even been, you know, created if not for the continuous ongoing assessment that a nurse engages in from the minute he or she walks through the door of that client. And it's not just a matter of, you know, how many times we're the ones telling the physicians what we think that they should do, you know? Yeah. So having said that, I think that people are really appreciative of what we do. And I think they recognize the level of risk that our job carries.
Yeah.
I just think sometimes our body of knowledge isn't as respected. And so that's why nurses aren't invited to the table as much. But we need to actually advocate for ourselves to be invited to the table to have these policy-making decisions, right?
And I think the next question we have actually kind of ties in with some of the stuff you were talking about before, sort of some of the challenges that went with it and all of that. So from your experience working with vaccinations during the H1N1 pandemic, what are some of the things that you think the general public should expect if/when a COVID vaccine is available? And what are some lessons that you feel have been learned from what occurred with H1N1 that could be applied to now?
I'm going to take that question a couple of different ways, if that's okay, because there were some.
Absolutely.
The whole premise of my research was for lessons learned. And so some of the actual logistical things I'll get into first is logistically, we need to be prepared as nurses and people working in different healthcare agencies for the sheer amount of people that are going to show up for the vaccine. If H1N1 taught us nothing, it was that people are scared. We're scared, and they're going to continue to be scared with COVID. Of course, you're going to have your people, your individuals that are nervous about taking the vaccine, but I do believe that once a vaccine becomes available, you'll have more people than not that will want to take it. So that what that's going to look like is you're going to have sheer amounts of people, mass amounts of people descend on wherever these clinics set up. And so it does really become then a point of safety in terms of having that kind of people, having that number of people present in one location.
Yeah, because I guess by the very nature of a bunch of people going to a clinic, it creates an environment where a virus could spread.
And a lot of people, what was saw in H1N1 and definitely seen quite a bit, is that people actually masked symptoms because they wanted the vaccine. They were scared. So they would do the pre-screener asking questions regarding, okay, so do you have a sniffle? Do you have a cough? Have you, whatever? And people would lie because they were just so eager to get the vaccine, if that makes sense. Also, too, people would become very aggressive if they were, not everybody, but it happened enough times that people would become very upset and sometimes aggressive if they were denied the vaccine, if they weren't a member of a priority pre-established population. So the thing is, there were, at the beginning of the clinics in Ontario, beyond Ottawa, when I studied, there was very little security set up at these clinics. So it was basically just the immunizers that would be sat down at the immunization station, getting ready to, go through the informed consent, give the needle, watch for adverse effects, and the patient or client would be on their way. And the supervisors that were making sure the logistics of the clinic were okay. And you really need to think about the safety and the security of your nurses as well, because if that's threatened, they're not going to be able to operate effectively or appropriately. And people get scared. People react in weird ways when they're scared. Fear is a crazy thing. And so if they feel like they're being threatened and not having access to a vaccine, if when one is secured, we have pre-established populations that are priority, that needs to be really planned for. Nurses were threatened, nurses didn't feel safe walking to their car, taking lunch breaks, etc., because they knew those mass amounts of people were there watching. That does a huge psychological role. So I think being ready for the logistics of what a clinic's actually going to look like, it's not like people in an orderly fashion, just waiting for their vaccine. And then I think on another level too, making sure that the message that's coming from all levels is the same and it's consistent and it's clear. Meaning if municipalities follow, your provinces, this is our pre-established population that are a priority to receive the vaccine first, that has to be maintained across the board. There can't be this person, that person, this person. And I know as nurses, we like to do that because we really want to understand the individual patient's context. But in that situation, you can have the nurse on the front line be the person to say to one family yes and to another no.
Yeah.
And they need to be supported in their managers when they make those decisions, because if not, you just feel like you don't have a leg to stand on.
Yeah, there has to be a firmness and consistency so that the rules can kind of be established and then upheld through the entire process.
Yes. So I think those are two of the biggest takeaways for challenges. And that's what I would think we'll see with COVID as well. Also, too, with the presence of social media right now, I think social media was present back in 2009, 2010, but nowhere near to the extent how much it's a part of our daily lives right now. So using that for good as opposed to evil, meaning let's use those mechanisms to really get those messages out clear, concise across multiple platforms. So it's not like, well, the person on Instagram said that he was able to get in even though he's not a priority population, and throw some poor innocent, frontline care provider under the bus. So they're going to make the best decision that they could at the time.
Yeah, that's a good point. I never really thought about, the kind of role that social media will play in these times with COVID. Yeah.
Oh, huge. Yeah, it's almost quite scary, actually, right? Because
Yeah.
with the ability to access information is the ability to access a lot of misinformation. So,
Yeah.
and target people,
Yeah, I can definitely say, just through living through this myself, I've seen so much misinformation be spread online. And when you don't necessarily like know much, say, about like the chain of infection or something like that, sometimes things can be pretty, people can fall for things that aren't true. And it's not necessarily any fault of their own. It's just because it's not about a subject matter that they necessarily know well. So
Mhm. Totally, I agree with you 100%. And that's why, I really feel that once you enter into one of the professions like nursing, your hat never comes off. Like
Yeah.
it's like getting into the mafia, too much to ever leave. So if someone is actually saying to you misinformation and you're able to have that rapport with them already, that they trust you enough for them to be like, oh yeah, Alana told me this, or, Ryan told me this,
Yeah.
Emily told me this. And I know it comes from a place of sound rationale and expertise, right?
mhm.
And then there's still going to be the people that are going to say, I don't care what you say, I believe what I believe. So
Yeah.
So with your with that extensive background in pandemic research and response from that nursing side, is there anything about the COVID-19 pandemic that has kind of surprised you or that you didn't expect?
I honestly, this might sound a little weird, but I'm surprised it didn't happen sooner.
Yeah.
So just with the whole nature of pandemic, um, so just to say really quickly, in case people truly don't understand, it's about degree of spread, not degree of lethalness. So a pandemic needs to be declared when it's in, more than 2 World Health Organizational regions. And so with the way that we currently live, with the ease of international travel routes, both for leisure and for agricultural, economical purposes, and the different types of agricultural practices that exist in all these different places around the world right now, and experimentation and just ways of life for different cultures, I am
Mhm.
so surprised that it hasn't happened sooner. And all the literature is saying that too, it was just not a matter of if, but when.
Yeah.
So since I, did my data collection and my research during the last pandemic when it was declared over in the end of 2010, I've just been waiting for it to happen.
Yeah.
Mhm.
So, you know, the surprising part about this time around for me, having looked at all the last 4 of the last, century of pandemics that have been declared, is the level of decision making and the types of decisions that were made to really accommodate the public.
Mm.
And what I mean by that is I sometimes wonder, and I mean, this is not based in research, this is just me anecdotally speaking here now,
For
based
sure.
on my background. I wonder sometimes with the effect of social media and with the effect of everybody having the ability to voice their own concern,
Hmm.
if people in different positions made decisions based on that public pressure,
Yeah.
you know? So it's interesting to see how those types of things can happen when people kind of come together and, you know, out of fear again, right? But
Yeah.
yeah, so that's one thing I really was interesting to me about the COVID. And I knew as soon as everything locked down this past April, when people were talking about getting back to normal in the fall, and even, even getting back to normal in 2021,
It's going to take quite a
it's gonna
bit.
it's gonna take this is our new normal for quite a while.
Yeah. Especially because it is, like you mentioned before, it's so new. Like for us creating an influenza vaccine, I wouldn't say it's trivial, but it's relatively a lot easier because we have the sort of processes to do so. But this is totally new, and we haven't really had a reason or a chance to create a successful vaccine for coronavirus before.
And again, the amount of safety things that have to follow that, right? Because it
Yeah.
is so new, and with regards to doing trials, right, clinical trials to make sure the
Mhm.
effectiveness and the safety of it, and it was a lot easier to do that with a flu virus, because we literally run one every year, right?
Yeah.
So I mean, it was a novel virus. It was a brand new influenza with H1N1, but it was still a flu rather. And I'm fascinated by how this will look different 10 years later because
Yeah. Yeah, I think I mean I've always kind of been interested in these sort of events that happen, and I think that yeah, looking back on this in a few years will be very interesting, just like it is for SARS and for H1N1 and for various other things, to kind of have that retrospective as to what that experience was like, and hopefully we can learn from it moving forward.
I hope so. And, I really, even with this conversation with you, you two, I said I'm walking away from H1N1, as did all the other nurse researchers and academics looking at SARS and H1N1 and Ebola outbreaks, and being like, every single time coming to the table and being like, we can take what we learned from these experiences, because like I said to you earlier, this is not a matter of if, it's a matter of when. So let's use what we learned and really have it inform our practice. Let's have evidence-based practice frontline the next, let's be ready to go, based on experiences, nurses' experiences. It's such a valuable piece of the pie that can help inform best quality practice.
So having worked previously with H1N1, obviously H1N1 was an influenza and COVID-19 is more similar to a common cold. So they are obviously different types of viruses, but how has the spread of COVID-19 been similar to that of H1N1, and how has it been different? Less on a medical kind of sense and more in a social sense.
People are scared of COVID, right?
Yeah.
For the most part, there are still people that are still very scared and, are having a hard time moving away from, when bubbles were eased this summer and whatnot, and more restrictions were lifted, even modified. There are still many people that were hesitant to go into that modification with the rest of society. There are still people that are still very much staying at home, keeping their bubbles. Do you know what I mean? And that's good if that's working for them and it's helping decrease overall societal transmission, right? But I think the fear is having such a huge mental health impact right now. Yeah. Whereas people with the flu, for example, we're so used to the word flu. We know flu season. Every year we all get our flu shot. Do you know what I mean? We're just so, oh yeah, I get sick with the flu. And, I recover. And the majority of people with COVID will also recover, right? But the different thing about this is that, and it's a good reason to be afraid, we don't know the long-term effects of this virus. So yeah, me or you as a healthy 20, 30-something-year-old person could go get the virus and recover, right? From symptoms. Yeah. But what will that do to our lungs, say, in 20 years? It's like they have an exposure to something, right? And a toxin, what kind of long-term effects will that have? Will it bring about something prematurely for me? Will it cause another mutation and a carcinogen? So I think you know what I mean? So that's why people are scared. So I think the long-term mental impacts of this are going to be quite significant. We're already seeing it now.
Yeah. Well, and the marginalized kind of get more marginalized from it. So the people that already have mental health problems or people living with drug addictions or other chronic health conditions or people of color, those are the people that are just kind of further getting marginalized by this as well.
That's a really interesting point, Emily, because there's already a noted increase in people that had substance, misuse disorders, eating disorders, exacerbations of usually managed depression and anxiety, just the perfect storm of things to help make this be a little more challenging,
I even saw that in practice this summer working in inpatient psych, the effects of COVID-19 on a socioeconomic kind of level, it worked its way into the mental health services, even the higher level ones, inpatient in the hospital. You could tell that there was something bringing a lot of people in. It was interesting to see in person.
It's sad, but it's our reality, right? So what can we do moving forward with each practice step that we make and each policy decision that's made?
Yeah. And already some great things have come from that as well, having RNs the ability to prescribe certain controlled substances for people who are facing addiction and such. Recently, I think that just came through, and so little things like that I think do end up making a bigger difference for sure.
For sure.
We hope you enjoyed today's episode. We encourage you to reach out to your healthcare provider for more information. As always, check out our Facebook page for additional resources related to today's show. Every episode is uploaded to our YouTube channel if you'd like to hear it again. If there are any topics you'd like us to explore, please contact us at asoundconstitution@gmail.com.